morning, everyone. And I would try to limit my talk to only acute case scenario because chest pain is like a vast topic. It's our bread and butter. It would not be possible to cover both ACS scenario and stable angina in a single talk. So let's get to it. Defining chest pain, one of the most important aspects. And there have been numerous studies, qualitative, quantitative, but till recently there were no uniform guidelines. There were no recommendations for us to follow that how to evaluate a patient with chest pain. That has changed in 2021. We have a formal guideline from ACC/AHA delineating an approach to chest pain. So all of my guideline recommendations included in this talk would be based on that ACC/AHA 2021 guidelines. So the key factor, key thing is we have to stop using the term atypical because it does not convey much sense, meaning to the person who is reading your records. So instead of atypical, you use the words like cardiac, non-cardiac, or possibly cardiac. That conveys much more meaning, much more sense for the record keeping. So how to do that? It's pretty simple, and we have been doing it for ages. Now, typical nature of the pain, retrosternal squeezing, heaviness, radiation, goes in favor of high index of suspicion, localized, sharp, all those things. And now it has been very well quantitated also, like radiation to right arm and right shoulder has a very high positive likelihood ratio. Both shoulders associated with exertion, radiation to left arm, associated with diaphoresis, associated with nausea, vomiting also. So these have high positive likelihood ratios which should be used in clinical practice, and we have been using it in clinical practice. There are things which decrease the likelihood of an ACS scenario, like chest being described as increasing with respiration, like pulmonary chest pain, positional chest pain, sharp, well-localized chest pain. If the patient can pinpoint, like here is the pain, it's likely non-cardiac. Inflammatory location, like if it is reproduced by palpation or pressure. So based on these, it is better to characterize the chest pain as cardiac, non-cardiac, or possibly cardiac if you are not sure. Then apart from the nature, there are other things like onset, the tempo in which the chest pain develops. It's acute, it's not sudden. If a patient comes and he says, I was fine a second ago, and in the next seconds I am having chest pain, that is unlikely to be cardiac. It is more likely to be either pneumothorax, something like an aortic dissection. Anginal chest pain typically has a tempo. It is gradual in onset. It develops over few minutes. It is never sudden. It is acute. Location, radiation, as I said. Severity, for angina, not so much, doesn't much help. But there are other situations like aortic dissection. Typically, patient describes it is the worst pain I have ever felt. Then there are precipitating factors which help us. Then the relief factors, although nitroglycerin causing relief has been traditionally used as a marker of anginal pain, it's not so much helpful. And in studies, it has been shown that relief with NTG has been quite common in like esophageal spasm. So it should not be like used as a very hardcore marker of anginal chest pain. Then associated symptoms are very important. Presence of associated diaphoresis, sinking feeling, nausea, vomiting are often present. And apart from the acute episode itself, we have to take the background into account, which is of immense importance. The patient's age, risk factors. So overall context, which determines the pretest probability of the patient having an acute coronary event. Physical examination, I think I will skip it because it's been already covered in the last. We have to exclude other causes of chest pain, and it's a routine part of our practice and care. Now coming to the ECG part. So when we say non-diagnostic, what we have been doing is looking for ST elevation, because we have been using ST elevation as a surrogate marker of acute coronary occlusion. We have not been chasing ST elevation per se, we have been chasing type 1 MIs, acute coronary occlusion. But what we have been doing for the past 2 decades or so is trying to chase ST elevation, and we have forgotten almost that it was not the ST elevation we were chasing. We were chasing acute coronary occlusion, type 1 MIs, because many often type 1 MIs, acute coronary occlusion, happen even without ST elevation. And it has been very well documented that at least in 30% of the cases, patients have acute coronary occlusions and acute coronary syndrome with no or minimal ST elevation, which does not fit the criteria. So any ST segment elevation, even if it does not fit the criteria, still has a positive likelihood ratio of 11.2 for likelihood of an acute MI. And similarly, there is a whole plethora of changes. Any ST depression, any Q waves, T wave peaking. Now we all know in MBBS days, hyperacute T waves is a sign of MIs. But I have many often seen hyperacute T waves being missed, or not the ED physicians not being confident and waiting. Oh, this is hyperacute T waves. We have to wait for ST elevation before we can do things. That is unfortunate, but it does happen. So to summarize what I have said till now, this is the typical protocol which we follow. Chest pain, we do history examination. Based on ECG, we categorize the patient on a STEMI. STEMI gets the 5-star treatment, urgent, immediate reversal within 2 hours, or as far as physically possible, thrombolysis. Whereas the NSTEMI guys, they are treated like as a third-class citizen. They get delayed devascularization after 24 hours. But the fact is, at least 30% of these NSTEMI guys have acute coronary occlusions. And it has been very well documented that that is associated with poor outcomes. But there is a significant subset of patients who have truly non-diagnostic ECGs, normal ECGs even. What to do? The evidence is clear. We have to do repeat ECGs. We have to do biomarkers and additional testing, which I'll come to later. So as I was saying, our STEMI, non-STEMI paradigm, which we have been following, and don't get me wrong, it's not without its benefit. It has streamlined acute coronary syndrome care, and it has gotten a tremendous quality improvement. But there are important pitfalls, because in this meta-analysis, which was published in European Heart Journal, they found that out of a total 40,000 NSTEMI patients who were analyzed, 25.5% had a total occlusion of a culprit artery, and the mean time of revascularization in this study was 34 hours. That is a phenomenal delay, and with current expanding access to care and cath labs in almost every 150 kilometer radius, and even in India, it's time for us to look beyond and try to improve the care. So the editorial which was published along with this meta-analysis, it did conclude that how to identify these acute total coronary occlusion in patients with non-ST elevation ACS. Is it like finding a needle in a haystack? Not so much. We already know there are a lot of markers of acute coronary occlusion which we have been detecting, which can help us detect acute coronary occlusion, like the De Winter's pattern, the subtle posterior wall MI signs. In LVB, not exactly absence of ST elevation, but we have criteria which help us improve the diagnosis of acute coronary syndromes. So how do we get to this STEMI, non-STEMI paradigm? The basis was that initial thrombolysis studies, they were not done on the basis of ECG findings. The diagnosis of acute coronary syndrome and acute MI was established based on chest pain and clinical. So in the initial studies, the ECG criteria was not used. It was not STEMI versus non-STEMI thrombolysis. It was thrombolysis for MI, and later on, retrospectively, we found that STEMI is the best predictor of acute coronary occlusions. But we have to remember that it is just a predictor. STEMI does not equate to acute coronary occlusion. It is the best predictor. But what we are truly looking for is occlusive MI versus non-occlusive MI. And that is what we should try to identify. STEMI is, of course, the most appropriate and easy way, but we can improve upon this STEMI paradigm by identifying other markers of acute coronary occlusion. And recently data is coming up, and there are at least 2 good studies published which have shed more light on this. I'm sorry if I can have just 2 minutes, please.
I'm extremely sorry, Professor Malik. As per the guidelines of scientific committee, we will not be able to have any extension.
So, okay, not a problem. But we all know, and my point was that we have to move beyond STEMI and recognize the other criteria. Thank you very much.
Thank you.